more than just inform. It aims to demystify, connect, and empower. It marks the beginning of what we hope will be a series of open, collaborative, and community-driven dialogues on responsible AI in healthcare. Our agenda reflects the breadth and urgency of this topic. We'll start by breaking down common AI terminology. We will then address AI bias and ethics. Who gets left behind, and how can we do better? We will explore the role of AI governance, dive into data quality, patient privacy, and ethical training of AI, and finally, confront the real risks and limitations of AI in practice. To guide us, we are honored to be joined by an incredible lineup of speakers and panelists, leading experts in their fields, who will help us unpack complex issues through shared, thoughtful, actionable insights. As healthcare professionals, we are uniquely positioned to shape how AI is integrated into care, with a focus on patient safety, equity, and dignity. Your presence here today reflects your commitment to staying at the forefront of innovation and to contributing to a future where technology enhances, not replaces, the human touch. We encourage you to engage fully, ask questions, challenge ideas, share your perspectives, and build connections. This evening is not only about education, but also about cultivating a vibrant and informed community that leads with both knowledge and empathy. Before we begin the session, I'd like to take a quick moment to express our sincere thanks to those who have made this event possible. Jubilee Health Insurance, for your continued support of all our healthcare initiatives. Thank you. Kala, for encouraging this essential conversation. Ismaili Civic, for your enthusiasm and getting us to push our boundaries. To our incredible speakers, panelists, organizers, and volunteers, your dedication and energy are deeply appreciated. So let us now dive in with curiosity, with purpose, and with a bold vision for what's possible. Together, we can shape a future where AI doesn't just power system, but uplifts people. Welcome.
Thank you, Chair Asmina, for the warm welcome and insightful introduction. We appreciate you setting the stage for our gathering today. Now, as we move forward, let us build on the foundation with our next segment. Before we jump into the discussions, we want to take a moment to gauge your familiarity with this rapidly evolving field. To do that, we'll use a Mentimeter poll that will allow each one of you to share your insights from the comfort of your devices. So get your phones or tablets ready. Whether you're an AI novice, a seasoned expert, or somewhere in between, your input is invaluable in shaping our conversation today. Let's get started. Keith?
Good evening, everyone. My name is Keith Mbai, data engineer and AI researcher at Kala. This session will be to know the room, to know our knowledge about AI, to know what we think about it, so that it can inform the discussions that can later on follow. If you will go to your devices to menti.com, menti.com on your browser, and then you input the code 6103 7659. You go to menti.com on your browser, you input the code 6103 7659. The first question deals with rating your AI knowledge and skills on a scale of 1 to 5. Oh, so the Menti is anonymized. We won't see who answered what. So you can feel free to give your honest answer. Just for context, in Ethiopia, there was a study done and health professionals rated themselves. About 50% were digitally literate and 50% were not digitally literate. Yes? Oh, the code is 6103 7659. 6103 7659. Great. As we let everyone answer the first question, I was saying in Ethiopia, about 50% of healthcare professionals will rate themselves digitally literate. Most of us are in between. Okay. Or let me also mention, for you to have AI knowledge and skills, you don't need to be a coder. There is low-code AI skills. You don't necessarily need to know how to build an AI program. Yeah. Just need to know how it works and the fundamentals. So right here, scientists built an AI model that spots endometrial cancer in tissue slides with 99.2% accuracy. It can be adapted to detect other cancers like colorectal or oral. Now, the next question is, what is the acceptable threshold of performance for AI? To give context, 400,000 hospitalized patients experience some preventable harm each year in the US, and in the same year, 200,000 patient deaths were due to preventable medical errors. So what's the acceptable threshold? Is it 0? Do we want AI models that can contribute to no single death? Is it half of the human baseline, the average? And if in statistics average, there are some who are higher, there are some who are lower. So do you consider AI to be the higher than the highest human, or just average, compared like on the same level as the human baseline, or at least better than the human baseline? I see some of us are very zealous for human life, which is very good. Oh, also, I didn't mention, I'm also a pharmacy student at the University of Nairobi. Great, thank you for your responses. At least better than the human baseline. Now, we have a fictitious case. So NM does not represent something that is either in Kenya law or something that happened. It's a fictitious case. NM is a client of Dr. J.A., also a fictitious doctor, rather. And Dr. J.A. was using an AI-powered cervical cancer screening tool with a sensitivity of 99.9%. It was launched in hospital XYZ. There's no hospital called XYZ. And it fails to pick up stage 3 cancer, which is discovered 2 months later. NM wants to sue. Who is liable? Dr. J.A., the AI developer, the hospital, or all of them? Again, we want to know who answers. And also, this is it's still a topic in medicine where there's no unanimous answer, where people agree. I believe Dr. Fred, who will be leading us through the AI lighting, will speak on this issue and WHO guidelines. See, the developers in the room are somewhat safe. Oh, all of them, so we are not safe. Okay, thank you for your responses. And this next is an open, it's going to form a word cloud. So I want you to put your honest thoughts. You have a maximum of 3 responses. So put in your honest thoughts of what you think of AI. Is it revolutionary? Is it dangerous? You can put like lack of data or such things. What do you think about AI when that word pops in your mind? Assistant. Great. Replacing manpower. I see an emoji. Again, we can't see who responded, so it's all anonymous. You can add an additional response. Replace human intelligence. There will be a Q&A session where you can ask questions particular to what you think. Making us lazy. The hype is no joke. Needs to be regulated. Needs human interpretation. Addictive. That's very insightful. Mind-blowing. Making us lazy. Uncharted. But most of us picked revolutionary and helpful and also dangerous. Okay. Let me allow you to mark your responses. I think we'll be able to share this later on so that you get to know what your peers think on AI. But I'm very happy that there's positive comments and sentiments about it, yet we have to take it keenly and with caution. Now, here's an interesting case where we have a paraplegic man in China walking again after receiving an AI-powered brain spine implant. These are things we see in the movies. Now, are you willing, or do you use AI diagnostics or any other AI tools in your practice? Or will you be comfortable if your doctor used AI tools? Especially on this slide, we won't know, so you can comfortably It's anonymous again. Great stuff. It's been really nice knowing you from a statistical level. We hope further we'll get to interact and get into these key issues. Let me welcome Dr. Fred. Oh, sorry. Let me welcome Farooq.
Thank you, Keith. Thank you all for your participation. Now that we've gathered some information on artificial intelligence, it's time to explore the topic in greater depth. I'm delighted to introduce our next speaker, Dr. Fred Mutisia. Dr. Mutisia is a practicing medical doctor and award-winning AI developer. He graduated with a bachelor's in medicine and surgery from the University of Nairobi in 2013 and is pursuing a master's in data science at the University of East London and a master's in field epidemiology sponsored by the CDC. As the health tech lead at Kala, he manages health AI initiatives. His recent AI solution on antibiotics earned the Impact Prize in Vienna. He volunteers with the Kenyan HIV program, received the 2020 PEPFAR Heroes Award, and is the ICT AI lead at the Kenyan Medical Association. He will be guiding us through a brief theoretical overview of AI. Please join me in extending a warm welcome to Dr. Mutisia.
Yeah, thank you for those kind words. How are you guys doing? I think we started off on a very good note. So my role will be quite simple. I'll just be setting up the stage for our panelists. And basically it's just to get some definitions off the ground. It'll be like a 10-minute session. So I started this journey of AI about 6 years ago. And as a disclaimer, I like showing that I'm an AI realist. You know, I'm not too much into AI. And here is a thought experiment that I like starting off with. You have two questions here. Feel free to choose any of the two. The first question is about how many dogs can you see in that whole grid. Take your time. But for the more ambitious ones, you can choose option 2, where this is a question that we had in our epidemiology class about modeling mpox. So if you're feeling like you know the calculus, you can always do question 2. But I'm sure most of us will do question 1. And when you look at how many dogs there are, on the first row you can see there are 2. On the second row again there are 2, that makes 4. On the third row you can see there are 2, that makes 6. And on the last row we have the first grid, and on the second last grid you have 3 puppies which are clustered together. And that makes a total of 10. So the funny thing is, if you ask the frontier models right now the same question, GPT-4o, Omni, and Claude, all of them get it wrong for the first question, like counting the puppies. And you're like, counting puppies? Like, I thought it was easy. And for us, it's intuitive that even if a puppy is hidden or the image is cropped, we still know that that's a puppy. However, AI models fail in terms of recognizing that. And that's the Moravec's paradox. And Moravec's paradox basically says what is easy for AI is hard for humans, and what is hard for humans is easy for AI. So if I was to ask you 259 times 150 times 292, you'll be like, no. But even with the simplest calculators, you get that result in seconds, right? Yeah. But with AI, it's so simple. And you know, sometimes you think the complex problems of you want to model something very complicated, look at that nice graph that you have, while the simplest things are what is a challenge. And I bring this out just for you to understand that AI right now has its limitations. And I'm cognizant of that as one of the proponents of AI. However, I feel bullish that there are some use cases which are relevant. So now that I've gotten that disclaimer out of the way, what is AI? So AI is not a new term. Like AI was coined about 70 years ago at a conference in Dartmouth in 1956. So the term AI is not new. And basically when you ask what is AI, it's basically a computer doing tasks which will require human intelligence. And when we think about AI, more and more times, it's harder to get somebody who is totally 100% AI native, meaning they haven't ever used AI, meaning they're AI naive, they have never used AI. When you wake up and you're looking at your social media, whether it's WhatsApp or Facebook, you encounter AI. Getting to work, whether you're using rideshare apps or you're using maps, AI. Right now, if you check your emails, like spam versus no spam, that's AI. And when you look at Gmail right now, it has a very good functionality that allows you to write emails. For my pro subscription, sometimes you want to reply an email and say, yeah, I agree with you. But you can't. You have to be proper. You have to say, hi, how is your day? I concur with those sentiments. Let us circle back. And AI makes us sound more human, right? And lastly, even Zoom. The funny thing is right now, Zoom, when you attend a Zoom meeting, there was a time I did a Zoom meeting, I was really excited. I had like 50 participants, and I was so excited. But when I went to the list of participants, I saw firefly.ai, read.ai. So right now, you'll find a lot of AI transcribers and just making work easy. However, what you notice is that between 8 and 5, the working day, we have an AI drought, meaning that we go back to our paper and pens, and that's one thing that we'll be talking about today. So just to get the whole setup, remember I said AI is not a new term. However, when AI started, the first forms of AI is what is called machine learning. And machine learning is basically statistics. And the statisticians in the house really know that they say, okay, AI is a fancy form of statistics. That was true 20, 30 years ago, but not true today. But the key thing about machine learning, it's the explainable AI. It's transparent. The same way from a logistic regression, you can be able to know what your predictors, and you can use that for policy. It's the same thing that you can use in machine learning. However, there's this thing called deep learning, which is a black box. And I know we have medics here in the house. If I take you down the dark road of neuroanatomy, of spinothalamic tracts, etc., you notice it like the brain is very complex. Like me talking right now, what gets me to talk? There'll be a connection to the auditory center, to the visual cortex for nonverbal cues, for short-term memory, long-term memory. If I'm a bit afraid, there'll be a connection to the amygdala, meaning that there'll be so many connections, you really don't know what gets me to speak. And that's the same thing with deep learning models. If you have a model that tells you this is TB, it's hard to know how did you arrive at the diagnosis of TB. Did you look at the lung area at the apex, etc., etc. And these are considerations when you're choosing an AI model. So even as now we talk about AI, I've already said that the overarching term is AI over 70 years old, nothing new. Then we have the subset of that, which is machine learning from the 1970s, basically statistics on steroids. Then we have deep learning, which is basically your brain in an artificial form, and that's why it's called artificial neural networks. Then at the intersect of that is what we usually talk about conventional AI. And when you talk about the domains, there's a domain called natural language processing, where it's basically, let's teach a computer how to understand language. So how to speak, how to write, and that's where we get our GPT, write me this email, etc. Computer vision is the domain that says, let's teach a computer how to see images and how to generate images. And that's where we say, make me a video of a cat jumping over a dog, something like that. So at the intersect of that is what we have generative AI. And that's where all the big companies are doing it. OpenAI has the GPT models. Right now, they're at 4.5. And we have the reasoning models, O1, O3, O4 mini. DeepSeek is from China. We have the R1 and V1 models. They really shot to fame because they basically did what OpenAI was doing, but at a lower cost. Claude is from Anthropic, which is backed by Amazon. Gemini is from Google. Llama is from Facebook. And also there we have also the models from Color. So basically all the tech companies are doing it. So let me just get a few terms out of the way. So one of the terms is large language model. So the key thing to remember is just large amounts of data, large amounts of text, images, etc. However, now we have a subset called foundational large language models, and these are the jack of all trades, meaning you can ask it a legal question, gives you an answer, a medical question gives you an answer, an architectural question gives you an answer. It's very broad, but the knowledge is inch deep. Once you start getting to the details, it starts fumbling and it hallucinates, means that it gives you answers which are not factually correct. However, now we have these foundational models which can be fine-tuned, meaning that you take a foundational model and you have a subset, like a medical data set. And suddenly, now you have instead of a jack of all trades, you have a master of one. And now that's a fine-tuned data set. Prompt engineering is a term that is used, and basically it's almost like, how do you speak to an LLM? I have a toddler right now, and he's almost at that age of asking those questions of why is the sky blue? So if a 3-year-old was to ask GPT and ask, I'm a 3-year-old, why is the sky blue? And you say, I'm a PhD holder, why is the sky blue? For the toddler, they'll say, the sky is blue because I love you, something like that. And they'll be content with that answer, like if it's a rhyme or something like that. However, when you're talking about a PhD student, you have to talk about the layers of the atmosphere, the wavelengths, and how it hits the light, etc., etc. So that is prompt engineering, basically giving context. Lastly, it's agentic AI models. And this is the most exciting part of large language models. I spend like 2 or 3 hours a day just figuring this out. So basically, agentic AI is, you have your large language models plus tools. And tools is anything that a computer can interact with. So you take a large language model, you give it access to the internet, and suddenly you have the most powerful research assistant who can give you a very comprehensive literature review of a certain topic. You give a large language model access to, let's say like Excel, like you have many Excel documents. And suddenly, you have a very good analyst who can give you, at the snap of a finger, very good charts. And you can ask it, no, I don't want this chart, I want this chart, make it this color, I want you to do this. And it does that. So this is the most exciting part of large language models as they are now. So I'll be finishing by talking about the blocks. What are the building blocks of AI? So I'll be using the illustration of a building. So when you talk about a building, what is the foundation? Like that's the strongest part of a building. And when you talk about AI, it's all about data. And when you talk about data, you ask, okay, what makes data good? It's quality. So when you talk about quality, means that if somebody comes and says, I have this AI model from China or India or from the US, the question to ask is, where does the data come from? Because the more representative your data is, the more local the data is, the better your model, regardless of how much they did or what fancy models or fancy architecture they use there. The better the local data, the better the model. Then there's the issue of quantity of data. So as I said, large language models, it's in the word large, so you need large amounts of data. However, you can't test every iteration using patient-level data. So sometimes, in the same way that we test drugs using in vitro methods before you go to the patient, a lot of companies are using synthetic data to be able to test these models. By the time they come to the patient, they have been rigorously tested for all these things. So the other building block for AI is the building plans. So we are thinking, okay, we have a building plan for a hospital, a hotel, And form follows function. And that's when you talk about models. We have thousands of models. And of note, FDA has licensed currently over 1,000 AI solutions. That is crazy numbers. However, it's yet to license any large language model because of some intricacies there that Keith had mentioned. So the other building block is human talent. So what is a human talent used in AI? So you have your data engineer. And your data engineer is the person who is concerned with your data. Like, is it clean? Can we ingest it in the right way? How do we make it AI ready? So this is the person who is concerned with the data aspect. Your data scientist is basically the person who builds the solutions. And your machine learning ops is the quality control person. So is this model robust in terms of dealing with bias? Is this model updated? Like, you have a COVID-19 model that was using data 2 years ago. Will it still be relevant in predicting causes of cough right now? So these are the things that the ML ops does. Then lastly, we have compute, which is basically the construction equipment. And when you talk about compute, there was a big fuss on OpenAI, Oracle, and that whole consortium committing $500 billion worth of compute. That's just compute. That's literally like 5 times the GDP of Kenya, just going on compute, meaning just data farms. That's the amount of investment that is happening right now. And Shiko will tell you, like, people like Strive and Cassava in Rwanda made similar commitments to do that now in Africa. So it's really exciting times in terms of compute. So I'll finish with this in terms of what are the use cases, even as we get into the panel discussion. So I've been practicing for about 10 years now. So it all starts with, how do you get the patient in the hospital? And guys like Jacaranda Health are doing great work in prompts, just ensuring that we're able to nudge people into the hospital system. Then we have, once in the hospital system, how do you triage them, identify danger signs? If somebody has a smartwatch that is saying that their heart rate is above a certain level, why do they have to wait? And yet the smartwatch is giving some indicators that they need to be seen earlier. Then we have decision support in AI, and Penda Health are doing a lot of work on this in terms of just ensuring that there's decision support. The keyword is support, not replacement. So decision support, AI-enabled radiology and pathology. We know the TB program in Kenya has been testing AI for TB diagnosis for a number of years, very promising results which were published recently. So yes, there is a very good ecosystem. And lastly, even as we think about the industry and AI applications, I was in a conference last year where there's this drug called Abos, in which the researcher took us through the whole process. So drug development takes about 10 years, costs like 1 or 2 billion USD, and it was done at a fraction of the cost and the time. AI is being used for research hypothesis, and there's a very good case study on Google AI co-scientist and hypothesis generation for acute myeloid leukemia. You can Google that. We know even our own KEMSA is doing a lot of work in supply chain optimization in terms of routes and forecasting. There's epidemic surveillance, and lastly, insurance, which I know our partners Jubilee will speak more on that. So that was me. Back to you, Farouk.
Daktari, maybe that question 1, instead of the number of dogs, maybe we would have asked ChatGPT how many muffins were there. Thank you, Dr. Mutisia, for the enlightening presentation. Your insight into the theories of artificial intelligence has provided us with a deeper understanding of the subject and set a solid foundation for our discussions ahead. We truly appreciate your sharing your expertise with us today. Let's give Dr. Fred a round of applause. Consider Mary, a 30-year-old expectant mother, living in rural Kenya. Her health and that of her child depend on regular prenatal checkups, but there's a catch. The closest health center is more than 50 kilometers away, and getting there involves a bumpy journey on an unreliable bus. And even if she makes it, there's no guarantee she'll see the doctor. Sometimes, after hours of waiting, she leaves without being attended to because the doctor is overwhelmed with too many patients. This is Mary's reality, but not just hers. It's the reality of millions of African women. In fact, Kenya faces a staggering doctor-to-patient ratio of 1 to 100,000, leaving the vast majority without timely access to critical medical care. In some areas, the shortage is even more acute, with facilities lacking not just doctors but also essential equipment. The 2023 health facilities census by the Ministry of Health indicates that 93% of Kenya's health facilities cannot provide basic outpatient services. The census, which covered over 12,000 health facilities, revealed that a majority lack the necessary equipment for basic services. For maternity services, 84% of around 5,000 facilities lack essential equipment. It's just not inconvenient. It's a matter of life and death. It's now my pleasure to welcome to the stage Dr. Shiko Gitau, the founder of Kala, who will share with us a fascinating snippet on how Kala has utilized artificial intelligence to address the real-world challenges such as this. Please join me in welcoming Dr. Shiko Gitau.
Thank you so much, Farouk, for this. Thank you, everyone, for having me. It's really a pleasure. I do not have a presentation. I leave that to the doctors in the room. But I wanted to talk on why we are doing this. And Farouk did preempt my presentation and my talk a little, and because you're in sync on this. Why AI? Why now? And why are we bullish around AI? It's a question that I get every single day, including this afternoon where I spent the whole afternoon with a group of researchers from across Africa trying to tackle research, moving research from labs to implementation and commercialization. But this is what we are calling the AI moment for Africa. It reminds me of 15 years ago when we all started experiencing mobile internet. I know for the Gen Z, they're thinking, what? Atrocity? What do you mean internet? Yeah, we never had internet 15 years ago on our mobile phone at the click of a button. Yeah? And we were all excited. I was a graduate student at the time, and our goal was to see how will Africa adapt the internet? How will Africa use the internet? What will the internet look like for Africans who for the first time will be using the internet on their mobile phones? That is just 15 years ago. When you look back right now with TikTok, Instagram, and WhatsApp, you cannot live without the internet. Yeah? The first place that you hear when you see shoes flying, where did you go first? TikTok or Instagram. When you hear a gossip about your family, where do you go first? Your WhatsApp group, right? It has become such an essential part of our lives. Yeah? Just about numbers, Kenya is the largest per capita user of which tool? WhatsApp, actually. Yeah? In the world, we are higher than India. Per capita user, every household in Kenya uses WhatsApp. But TikTok is the queen. It is the highest adopted technology in Kenya per capita user. This means that we are already there. We are using these technologies, but we've been left behind. It's not our technology. It does not have our context, does not understand our slow internet, cut internet, no internet reality. what AI provides for us is an opportunity for us to actually engage in that space. AI for us is that AI moment, is how do we make AI an African intelligence? Not just artificial African intelligence. We are not there yet. Africa forms about 20% of the global population, and will be 25% of the global population in the next 10 years, by 2040. How much of our data sets are informing the current AI models that we've just seen? Less than 4%. To be exact, 2.5%. We have over 2,000 languages on the African continent. How many of them are digitized? Anyone wants to take a stab? Farouk? Farouk has refused to answer that question. None of the medical students here know. Only 50 of the African languages are actually digitized, which means 1,950 languages are not digitized. This makes it very hard for us as Africans to be able to say artificial intelligence, as Sundar says, is the truest information about Africa, about humans. Africa is not represented in that artificial intelligence, and we have to, as Africa, be able to be represented. The most important thing is about work, and that's a question I'm sure is going to come out. AI is going to take up our job. But Dr. Fred said something that I was hoping he was not going to spread because he was going to preempt what I was going to say. Is AI going to take away my job? No. The person using AI is going to take your job. Yeah? Again, AI replaces what we are poorest at. No, what we are best at, not what we are poorest at. So what we are best at as humans, our intelligence, let me just go back. AI represents our intelligence, not our humanity. That is what I wanted to say. And what does our humanity is made up of? It's made up of our ability to care, ability to love, ability to see, recognize, and critically analyze with empathy. Because AI can analyze, but without empathy. And that's why judges are said, I can analyze this piece of case using AI, but the final judgment will come to my gut feeling. Why am I feeling about that? So we were on the table looking at your statistics, and my question I was asking the doctors, because we have like 3 doctors in our team, medical doctors, not doctors like me who run away from blood. And I wanted to understand, in addition, and this is a question I want to ask, in addition to saying 95% of you said you use AI in your work, at what point do you use AI in your work? I can see you discussing on your tables. Is it in diagnosis? Is it in giving prescription? Where is it that you use AI in your work? And you will tell me it's not in the hug that you give to your patient when you're delivering sad news about their health sector, their health status, yeah? It's not the kiss that you give to that child after injecting them. And those are the things that are about human. So even when we're talking about this, remember that as Africa, as humans, there are things that AI will never replace. It will never give you that hug. Yeah, they have tried simulating hugs. I mean, we're in this space, we've tried simulating hugs, right? But there's a touch, a human touch, that everybody cannot be replaced. And for us, AI, while it will never replace us human being, it has jump to a place where we can actually start competing with the world. Right now, and I know there has been a big argument on the internet and all WhatsApp groups that I'm in that are made of medical doctors. Bill Gates, 1 week ago said, anybody know what Bill Gates said? A person who is not Fred. So Bill Gates a week ago said that AI in the next 10 years will replace medical doctors. That is prediction. He said it will replace 2 careers, medical doctors, and will replace teachers. Why? Right now, and I was telling Dr. Fred we should have done that exercise. As a rogue non-medical person, every time I get that prescription thing that you guys with bad handwriting give us, What we do is you take a picture and upload it on ChatGPT, and it tells me what you're saying. Initially, I couldn't be able to do that, right? My sister was diagnosed with something terminal. We all didn't understand everything that came. We put it and say, do it for me like I'm a 5-year-old. And it explained it very well. Yes, that's what AI can do right now. And as technology progresses, some things it can be done. But should we throw it away? Should we say we cannot use it? The answer is no. Going back to those statistics, one doctor for every 100,000. But here is it. Who's a pathologist here? Your work is a pathologist. There's no pathologist here. Which is actually statistically correct. Africa has 3,000, 3 years, comma, with 3 zeros. Pathologist. Yes. So if the cancer diagnosis you are seeing here was something that was being delivered to us live, guess what? It takes 40 to 90 days to get a cancer diagnosis if you're living in Moyale, Nakuru, Eldoret, not Nairobi. Why? Because our 300 pathologists in Kenya, 180 of them are where? In Nairobi. And the 120 spread across the country are overworked. AI can help with tools like that. That's why we are bullish. It can deliver the best with human intent and support. We don't believe that AI will fully replace humanity. We just believe it will augment humanity. In fact, my former boss, Bob Collymore, used to call it augmented intelligence, because it will never fully replace humanity. And finally, Africa has 1.5 billion people. Will be 2.5 billion people in 2050. 80% of those young people will be under the age of 30, which means that we need to create jobs for them. We will be the world's workforce. How do we prepare our young people to be the world's workforce? There's a lot that can be done. And everybody who is freaking out about AI, there's another sector that is coming up that is adjacent to AI, and that is energy. We need mechanics. We need electrical engineers. You know fundi yako, the fundi for electricity? They'll be the highest paid people in the next 5 to 10 years. Why? Because AI needs energy. And fundis cannot be replaced by AI. Yeah? Carers cannot be replaced by the AI. The hug I told you about cannot be replaced by AI. Yeah? Cleaners cannot be replaced by AI. Our community for loving each other cannot be replaced by AI. So even as you're going to the next conversation, what I want you to do is remove the doomsday thing in your head. Forget what Bill Gates has said. Is how do you take advantage of that amount of knowledge to make sure you're operating at the same level as somebody who is as at the Stanford Medical School. Oh no, also Harvard. Harvard Medical School is like one of the highest ones, right? Or it's Johns Hopkins. Whichever is your favorite, right? How do you start operating at that level? Delivering high-level care to Africa is we have to start. We have to start, some of you, helping us collect data to train for the African skin, African blood type. Fred has been teaching us the way, even, was it malaria? For me and somebody who is born in Central, Nairobi, and Kisumu, malaria is different. I'm thinking, wait, what? And I just take malaria queen. I said, no, it's different how it manifests itself in different people based on where you are born, not just on your skin care. But the world does not know that. We need to start informing this. We need to start investing on you as our talent. So the medics, and I was happy this room is very different. We've run this training in another setting where the people who know AI were on the other side. There was 0 to 1. Like 0 to 1 had the highest number of people. Because medics are known to be the least digitally literate and AI literate. Why? Because you spent 7 years in school, you know everything. No, I'm just making a joke of you. But that is true. That's what I say. Because I know everything, but most of it is, I don't want to rely on a technology that is going to enable medical error as I'm working on this, right? That is usually the biggest fear. But how do you open up to this? Number 3 is how do we invest on use cases? That's why us guys hired a medical doctor, a very highly qualified one. Why? Because we realize we want to build these amazing tools to solve for health. I run away from blood, literally. Like, it makes me freak out. But how do you solve for that? Is you get somebody who is comfortable with blood and death. And they're able to help you walk through a medical use case. And coming back to what Farouk mentioned about Atunzi, I remember when you were mapping out the patient user journey, and I feel like because Fred is a very good doctor, he dropped the one part that all of us know we always go through, the familiar stage. You doctors, you know somebody said, yeah, I've been feeling it for like, I think 3 months. I've gone and taken Panadol. We call it a familiar stage. Is that stage before you go to your pharmacist or your chemist, is the actual word, and talk to this guy with a lab coat, and they give you Panadol and some antibiotics, because antibiotics heal everything in Kenya. Yeah? It's true. So as we are mapping out that patient journey, and with the doctors, we realize that we need to be able to have interventions at each stage. But which is the one intervention that will enable all the others to thrive? And that is keeping people healthy in the first place, especially for young women. Because young women are likely to be able to abuse medicine or be in suffering without telling anybody, especially from a reproductive health point of view. So Atunzi is solving for that, yeah? And you're hoping to make it into a proper medical companion for especially women throughout their life, yeah? I'm cramping. I want to engage in sex at 14. What should I be doing that? And it deletes. So one of the key things that we got from the medical doctors that Fred has been working in is some of these questions is you ask and make sure it disappears because you don't want your parent seeing some of that results. And that's why you as doctors need to start engaging in this space. Because us as techies, we love building stuff. But we need to build something that is relevant for you, that is moving your agenda and moving your field further. And finally, today I said I spent a time with a scientist, and one of them was a genome editor. Yes, here in Kenya. And he was being bashed around being a GMO producer. And he asked a question that really tickled my brain, is, without GMO, do you think we'll all be alive? And everybody said, yes. Then he said, we just from lunch. What did you eat? Fish, potato chips, and cabbage. When you're chewing, you just edited genes and DNAs for those food to create a GMO that is a meal that is supposed to satisfy you. How do you break down your language to a language that people understand? So that when people hear they have cancer, they don't think of death and give up on life. What is the language that we need to start speaking? So that's my challenge, and I'm excited about, let me check if I've said everything. I'm excited about this, and just talk about Kala. We are a Digital Innovation Lab. We are headquartered here in Nairobi. We are an African company. We have presence across the continent, and in Europe, and in the US, and our goal is to catalyze Africa's digital future. Our goal is to ensure that Africa is building our own technology. We are no longer a consumer, but we are a producer. Yeah? And we are looking forward to working with each one of you to make sure that we have an AI future that is actually relevant for the African continent. Thank you very much.
Your explanation on how Kala leverages artificial intelligence to tackle pressing issues was both enlightening. We are now excited to present a panel discussion focusing on various facets of AI and its applications within the healthcare system. Joining us are esteemed subject matter experts, each bringing their unique insights and experiences to the conversation. This discussion will be moderated by Rachel Osendo. Rachel is a law reform expert and public policy specialist who has led over 50 strategic law and policy reform initiatives across sectors, from reproductive health and education to trade, intergovernment relations, disaster governance, amongst others. Rachel will guide us through the topics and ensure a dynamic exchange of ideas. This promises to be an engaging and informative session, so let's dive into it. Rachel?
Good evening. Farouk forgot to mention what I do for CALA. I lead policy in CALA. So you heard what Dr. Shiko said. And CALA is being very instrumental right now in terms of the agenda for Africa and AI. So one of the initiatives that we drove was to have the Africa Intelligence AI Declaration. This was signed in Kigali in April, and it was signed by about, I'd say, over 50 ministers, over 50 ICT ministers. So this is an Africa agenda that is happening. Thank you. The second project that I'm leading is the AI Masterclasses, which we are curating one for you now. So we're doing this for policymakers, and we've already done the Kenya version. We did that on the 10th of April, and we're targeting 5 other countries in Africa. We're targeting Malawi, South Africa, Senegal, Rwanda, and Nigeria. But then we also have requests from other countries, Cameroon, we have requests from Equatorial Guinea. And so, you know, this is it. When you're asked to do a masterclass, you say, we can curate it, we can partner. So we already did a masterclass for health practitioners in Kigali, and we did this under the Africa Health Agenda International Conference, right? So we're glad to be here. So that is what I do for CALA, amongst other aspects around policy, which are far and wide. So I'd like to introduce my panel. My panel has 3 members. I think I'll begin with Dr. Fred, who was already introduced by Farouk. So Dr. Fred is joining my panel. And then we have Debbie Mate. Debbie, as she walks over, I'll just introduce her. Debbie is an optimist dedicated to mental health advocacy, education, and capacity building. She thrives in supporting individuals, families, and communities in designing workplace wellness programs. She advises NGOs, corporations on safeguarding policy and wellness and training. She holds a BA in psychology, a diploma in international leadership, and she's currently pursuing an MSc in AI applications in mental health. Debbie, you're welcome. Dr. Fred, you're still welcome. And my last panelist is Dr. Musa Misiani. Dr. Musa Misiani is the Chief Operating Officer with Jubilee Health Insurance Limited. And Dr. Musa holds a Master of Science in Human Anatomy, Bachelor of Medicine and Bachelor of Surgery, and a Bachelor of Science in Anatomy, all from the University of Nairobi. He's also a Fellow of the Life Management Institute and an associate of the Insurance Institute of Kenya. Dr. Musa brings a decade of expertise in medical services management, clinical care, health informatics, and academia. His career blends hands-on patient care with operational leadership and scientific rigor, making him a dynamic force in transforming healthcare delivery. Dr. Musa, karibu. So I hope my panelists are ready. I was supposed to have a debrief with them just before we started, but they declined. So I think we just proceed. Thank you. Great, good. So I think we can get started. Dr. Musa, I'll start with you. And I like that we've already set the tone. Dr. Shiko, thank you for setting the tone. Dr. Fred, Farouk, Keith. So I think what we're trying to say is basically that AI is us, right? I think when we think about artificial intelligence, let's not forget that that particular machine has to be fed. It has to be inputted with certain data. It has to be inputted with information from you, right? So artificial intelligence, again, remember, it's an extension of you. So when we think about AI, and we think about AI and what you're doing with Jubilee Health Insurance, so it's not really about machines. So I just wanted to explore, what is Jubilee doing in terms of using AI, to improve processes, from claims, to better risk management or better risk assessment, but at the same time, how are the patients getting a good experience, even with the use of AI?
Thank you, Rachel, and thanks everyone for being here. It's a definite pleasure to be around and just to have this chat. Jubilee Health is a unique company. It's a unique underwriter in this country, in that we are the only ones who just do medical insurance from morning to evening, every day, 24/7. And it's allowed us to sort of just focus on how best we can deliver health insurance. And health insurance, when you think about it, it actually is an intersection of three sciences, very, very complex ones, really. There's actuarial science, on one hand. There's underwriting, which is a different science entirely, and medicine. All of those are data-driven sciences, and it would be quite difficult to have one person who's skilled in all. As a matter of fact, there's none, really. I've not met a doctor who's an actuary and an underwriter at the same time, or an actuary who's a doctor. Haven't. What AI has allowed companies like Jubilee to do is to blend these huge data sets together into a concise underwriting language. What that does is it allows us then to be able to process claims better, for example. And I'll give a use case for claim adjudication. For you to adjudicate a claim, you'll require that you have an understanding of the policy that is individualized for every patient, for every customer that has purchased your policy. You'd also want to understand the purchasing that you have done with the provider. You may have agreed a different price list with provider X and a different one with provider Y. You need to understand the clinical language, some of it handwritten, and Dr. Shiko mentioned doctors love scribbling a lot. I hope I'm not one of them. I don't scribble. I try to write in good handwriting. So it requires that it will be able to recognize that handwriting, recognize what the doctor is speaking about, code the correct diagnosis, and then adjudicate the claim, so that you can determine it fairly. What that does is establish consistency across. We have, for the past 3 or so years, used AI to adjudicate especially outpatient claims. And over that time, we have learned many things. Learned that AI requires time to learn. AI often counts 8 dogs instead of 10, right? But then if it does it the second time, it will count 9. And finally, it will count 10 consistently. And over time, that actually establishes some level of consistency in actually capturing a lot of what needs to be done and adjudicating per policy correctly, which is very significant for us as a regulated industry. Now, over time, you will start realizing that when the AI recognizes that for this diagnosis, this is the right treatment, it will be able to pick out waste. And we've been able to pick out waste quite well. It will be able to pick out unnatural patterns. So it picks up fraud very well. Now, waste and fraud would be assumed to be victimless problems in insurance. They could be assumed to be problems of the underwriters. You find a way to make profits with the fraud and the waste, but they're not victimless. The ultimate benefit of an efficient system is actually the customer, because someone has to pay for the fraud and the waste. Unfortunately, that cost is passed on to the customer. So when you actually optimize your efficiencies, you'll find that at the end of the day, you're pricing your policies more optimally, they're more affordable, they're more reachable to many people. And what we are trying to do as well is ensure that we are creating not only a health insurance company, but a health financing ecosystem. So if we're opening up an ecosystem of health financing, we can't do that with the inherent inefficiencies that existed without the technology underlay. Yeah. Then just on top of that, probably a good side effect that initially we didn't go in thinking about is the fact that we have very good feedback and a lot of data that we can feedback back to the provider. Over time, what that has done is create learnings in between us as the underwriter who see, okay, by the way, this pattern of illness has been picked in your facility. Maybe we could do this better. And that partnership has existed. It has actually led to improved patient outcomes for some of those facilities. And that's probably one of the most exciting bits for me. Yeah.
Okay, that sounds extremely exciting. So our patients are satisfied.
Yeah.
Is that what we're saying?
Yeah.
So the human connection, the human aspect of care is actually being met through this.
Yeah.
I think that's interesting. Debbie, I'd like to take the next question to Debbie. When we're speaking about the human connection, and I think this is what we're saying, that the patients are satisfied and the human connection is there. Looking at the area that you work in, the mental health spaces, I think in the mental health space, there's a lot of unspoken words, sometimes maybe hesitation, maybe unwritten statements, So just thinking about that particular space, he's talking about patient outcomes that are good. When you put in AI in all of this, is AI able to pick this particular emotional context, the care aspect, when you think about medical care?
Thank you, Rachel. I think I'll answer that by just asking first in the room, how many of us here have seen a therapist in the last 2 years? Okay. So I don't know what your experiences have been when you've gone to a therapist, but many times the feedback that we get is sometimes you go to a therapist or to a psychiatrist, and the moment you sit down, especially psychiatrists are the ones who are blamed a lot for this. So you sit, they ask you, so they run down their list. Have you been sleeping well? Have you been eating? When was the last time you showered? Oh, I think you're depressed. And they're quick to give you a prescription. And on the other hand, we have psychologists who, people say you go to them and they just sit and listen. And if you don't know what to say, they're just present. So where do we find the balance? Some people have said that sometimes AI is a balance because you have a little control where AI is concerned. And that's true. AI has a role to play in therapy. Because many times, say, at 3 a.m., somebody's in distress. Where do you turn? And often we realize that people who are in distress, family is not always the first people you go to, and you'll most likely be with them at that hour. So often we're finding it's easier for you to pick your computer, your phone, and there's somebody on the other side, there's a chatbot that's willing to listen, and many times they'll say, okay, tell me a little bit more about what you're feeling. And because of all the data that's been input into the system, it's able to pick up even from where you are, your location, your culture, like if you're in a Kenyan context, it will most likely speak to you about things in your environment that you will relate to. But what Rachel has asked is true. Does it give us a hug? Like what Shiko was saying? Is it able to say, oh, it's okay, it's gonna be all right? It will tell you that, but you also want somebody to look you in the eye and say, it's gonna be all right. Sometimes you need somebody to say, you're not the only person going through this, I totally understand, and it's gonna be all right. So that's a human aspect that AI doesn't capture. Many times we find clients who come and, yes, before you see a therapist, you know what you want to talk about. But then you walk in and sometimes you're overwhelmed with emotions. And sometimes you'll just sit and look at each other. And as a therapist, you give people time to process it. And somebody might just come up with a word like, why? So can you imagine if you were typing into a computer and you said, why? You know what ChatGPT will tell you? It will most likely go back to your history and pick up something. Maybe during the day you talked about food, and it will ask, did your food burn as you were cooking? Yes, that might not be the issue that you have at that point. But when you have a human, a face-to-face interaction with somebody, sometimes somebody looks into your eyes, they see your body language, they see the way you're slouching, and they're able to tell your concerns are not just about the things of this world. There's something deeper that needs to come out. And sometimes it comes out just with that reassuring look, sometimes with the assurance that somebody is listening. And I think those are the challenges that now AI developers need to get into, where trying to find ways of incorporating empathy into the apps that we are using. I think that's a challenge that I would throw to Shiko and the team.
Thank you, Debbie, for that. I think it's the presence you were speaking about. Sometimes there's the solace. I know I have it. There's the solace of seeing the doctor, of seeing, physically seeing the doctor. In as much as you may have consulted a tool, but then as we speak about presence and as we speak about the tools, and I think Fred, this question would then come to you. If we're looking at equity, if we're looking at the ability for everyone to be able to access this healthcare in a wholesome way, so we have the human doctor, but we also have, the AI tools. What are the ways in which, and Fred, you're wearing both hats as a doctor and as an AI innovator, what is the value of, doctors or health practitioners being involved early in the design of tools, and how can they also ensure that the design of these tools are also taking care of patient interests?
Yeah, that's a very good question. And I think I would summarize it in 3 ways. We need doctors in the room to help in co-create, co-develop, and co-test these tools. So when you talk about co-create, I started my career as a medical doctor working in Narok County. And I can speak about the many times you're called for a meeting, yeah? There's this awesome thing that has been developed in somewhere, and it's brought you, there's a whole projection, and you're told we'll implement this, and we'll do 1, 2, 3. And sometimes you do it because you've been told you have to do it, but there's this thing of adoption when you are there from the very start. Because doctors, there are some pain points that only doctors can understand. So how do we ensure that the innovators who are making things in their dark corners, I can speak to this corner. So how do we get into those rooms? And I'm glad that Chico understood that from a very early point and brought doctors on board. We've had doctor roundtables where we bring doctors in the room and they speak everything, and we have coders and we go through the whole co-creation process. And so when you talk about co-creation, we are thinking, not every idea is valid in health. We don't need to spend millions of shillings and man-hours for something to get to the market and suddenly the doctors are suddenly hesitant to adopt it. So basically, co-create. The next thing is co-develop. So we notice that there are some tools which need tweaking. And the tweaking that they need is insights. Like literally 2 minutes with a doctor would save a developer 20 hours of Googling and trying to troubleshoot something. So co-developing is one of those key things that we see as a place that doctors can innovate. And when you talk about co-developing, the biggest proponent of AI in radiology is actually the North American Radiology Association. And they host competitions on Kaggle where they give data sets and people innovate using the data sets that these radiologists use. So the last one is co-test. And here's the tricky thing. One of the hats that I wear is I'm the ICT and AI lead at the Kenya Medical Association, and we have 5,000 doctors. And one thing that I've been trying to lead is doctors as beta testers of these solutions. So before it even gets to the patient, come get doctors in a room and say, try this. What did you find? Is the UI, meaning the user interface, does it work for you? The user experience, are you clicking too many things? Like, for example, I had this solution which was an EMR to be used in maternity. And the feedback that we got from the nurses was, when I'm doing my delivery, I cannot type anything because I'm wearing gloves. And suddenly somebody was saying, this is a tool that was supposed to be used to help mothers when they are bleeding and help the nurse innovate and think, okay, this could be uterine atony, what should I do next? But it still wants somebody to type, the mother is bleeding. So such things of the user interface really come on board. And not just doctors, we are talking about the whole ecosystem of medical workers, from nurses to the lab scientists, to the mental health workers, to the community health practitioners, who are over 100,000. How can we get them on board to co-create, co-develop, and co-test these solutions?
Thanks a lot for that, Fred. How many of us in the room have co-created, co-developed, or co-tested any AI tools? Okay, not too many, but yeah. So I think that's the spirit that we should leave this room with as as healthcare professionals. Let's get involved, because there's no other way we can speak about AI coming, as though coming from where. Okay, so we should actually we should embrace, we should co-create, co-develop, and co-test. So I think this brings us into the human in the loop system. So sometimes, some part of the day, I'm a lawyer. I don't normally say it, but I do some legal work. But we have AI tools ourselves. But one of the aspects that you'll always find in the AI tool is that as much as you get this advice, kindly consult your lawyer at the end of the day. Kindly consult your lawyer. And I'd like to believe it's the same in your sector. So when I'm speaking about the human in the loop system, so we have artificial intelligence, but we have the human in the loop system. Remember, again, also, in the beginning, it is the human. But then, of course, now it's operating at a faster pace than you are. So, Dr. Musa, in terms of the use cases that you mentioned, it's very exciting to hear about waste, talking about the patient outcomes. Do you have human in the loop systems? And when you're creating these particular tools, did you involve patients? Did you involve the health professionals? Was it something that was, co-created? Was it inclusive?
Yeah, thanks, Rachel. At the end of it all, any health financing system, the focus is really the patient. And it's about the experience the patient has. So when we adopted this process, it was really just to make our claim processing system faster. We've learned some lessons along the way. One of them is the human in the loop. I think, Doc, you mentioned earlier, people do come and pitch very good ideas and have a good engine. Let them adjudicate the claims. The good thing about what we did is, initially we ran a parallel test. So we didn't deploy it entirely fully. So we still had our normal adjudication system and then the AI system. And over time, we kept training the model. Initially, it had about almost 40% error rate. Of course, that can't pass as an adjudication system. It's taken quite some time. Luckily, we have a good data set. Over time, we've been building that. And it's gotten to less than 2% error rate compared to, say, around 5 years ago. If you were to look at the human adjudicator, it would take them about 10% error rate. So actually, the outcome is better now with the model. But it could not have gotten there if we didn't have a human teaching it, testing, teaching, and actually deploying it. Because these are decisions that have a human impact. And I think we were discussing some time back with Dr. Fred and Farouk when we were discussing setting up this. there's an ethical question to application of AI, and I know it will probably come up a bit later. Yes, you develop a solution, but you can't really deploy it without testing it properly and making sure that, because it's making decisions that have a human impact. The financing decision you make decides whether someone is going to access care or not. You can't entirely leave it to a machine learning model, really, no. There has to be a human who actually adjudicates the decision of the AI. So we have a very robust QA process that has a human team behind it. Jubilee Health has about 5 doctors on staff full-time. We have about 35 or so nurses and about 30 clinical officers and pharmacists. So we have we run a hospital, basically, that is able to look at the decisions that the AI makes and QA it. Yeah.
Nice, nice. So I think that gives me a lot of comfort, gives me a lot of solace to know that, we're not entirely throwing this to a machine, but then we're ensuring that it's, like we said, co-creation, co-development, co-testing. Debbie, just to say one aspect around. So how do we then, how do we ensure AI supports, for example, the human connections? And I think it's the human connections in healthcare. How do we say that AI should support?
I think at the end of the day, we, especially being in this setting, in the African setting, and appreciating the fact that we're quite a relational people, the challenge now is for our developers to find ways, creative ways of bringing out a way where we can interact with our machine but still not lose the human aspect. So that even when we're developing, different applications for our communities, to be able to fast go, like what Fred said earlier, be able to involve the community. Who are the people we are developing these things for? What are their values? What are the things that they highly appreciate? And then put those things into account when you're developing whatever apps it is. Because then we do not want to lose, as much as AI is taking over, we still have the communities that we live in. We still, these applications are being created for us. And we need to be able to put into consideration what are the things that I, as Debbie, when I want to sit and interact with an app, what are those things that I know I do not want to lose? Then if I find an application that meets that need, it's very easy for me to take it up as compared to if I go to an application that I feel is a bit foreign and it doesn't totally meet my needs. I think that's what we'd consider.
Thanks a lot, Debbie. So I think, Fred, maybe you could give us what would be the call to action? I'd imagine we have had this session. I think the healthcare professionals in the room, they have had, co-test, co-develop, co-create, but where would they begin? Where would they begin? Where are the opportunities? And where are the ways in which we can lead, as Kenya, as Africa, in terms of our healthcare systems? How do we do this?
Yeah, definitely. The one word that I'll share is be curious. The good thing is AI is very democratic. The information is out there. It's very few of these AI solutions are behind a paywall. A lot of them have free versions, and testing doesn't cost anything. So I'm part of a team that is writing the AI guidelines for health, for the Ministry of Health. And one thing that we're finding a struggle is definitions. And that's one of the things that we want people to be curious, to the point that we can be able to define who is a health AI practitioner. We can be able to define who is a AI health expert in terms of ethics. Because right now, people are not yet in the field to a high degree that we can be able to define those roles. So a lot of it is experiential. So be curious, and I would just say about what Kala is trying to do. So right now, Kala has a health AI sandbox, And what we are trying to do is to have a gentle introduction of AI solutions into the market. And part of that is have a gentle introduction of medical practitioners into the whole AI ecosystem. So Keith has been organizing very excellent and interactive AI roundtables where we invite people from diverse health backgrounds and we just discuss AI. And we'll be going forward to have these gentle introductions as such settings like this as small short courses, but now which are customized to our setting. So even as we partner with different providers to give all these solutions and all these avenues for information, the call to action for us as medical practitioners is be curious. Be curious so that the opportunity will not pass by. People are curating solutions for us, they're curating AI education platforms for us, and all that we need to do is to be curious. Thank you.
Excellent. Thanks a lot, Fred. I'll round off because we want to go into the Q&A session. I'll just round off by saying that I get a lot of questions. People ask, should we regulate AI? And then, I ask them, so what is AI? Then, of course, you say, it's a machine that's, performing what a human being does. So who is feeding the machine? I ask them and they say, okay, I'm the one feeding the machine. So is AI a reflection of you? Then they say, yes, it should reflect my values. So artificial intelligence should be fair. It should be kind. Yeah. It should be accessible. It should be, so whatever values you hold as a person or as a human, would like to believe that artificial intelligence then should also hold those particular values. So I think from what we've learned on this panel is that AI is there, it can support us. It may overlook some aspects, but it can support us. But this is the reason why we still iterate. So we iterate to see how can we eventually make it better. And we've already heard about the human in the loop system. So we'll get into the Q&A session. The panelists are here to answer any questions.
Good evening, everyone. My name is Susan. I'm a data consultant at Dalberg Data Insights. And I have loved the conversation so far, and it's very exciting to listen to how AI can work for us in Africa. But something I think that we also need to nudge as a conversation is AI in Africa, particularly in low-resource environments. When you think about the question, for example, who has gone to a therapist in the past 2 years, if we take this conversation to, where are we, in Parkland? If we take this conversation to, like, Kibera, for example, and we ask them who here has seen a therapist in the last, give them even a longer range, in a space of 10 kilometers could be big, but you can imagine that the number of people who will even respond to that question will be lower than the people in this room. If you think about AI in health, which is really what we're here for today, if you think about the lowest level of healthcare access, think about sub-county and those level 4 hospitals. But basically, those hospitals that struggle with things like resources, they struggle with medicine, they struggle with support, basically. How can we democratize AI to these people? How can we spread these AI solutions, these AI use cases, and communicate this to those low-resource individuals? Unfortunately, AI can be a very exciting topic, but if you look at Africa, if you look at AI in general, it is reaching middle class going up, unfortunately, to a lot of people. But if you look at Africa, particularly the areas that need the highest level of care, these are areas that have little to no connectivity. We might go into an AI use case that is doing remarkable things, but these remarkable things cannot be done when we do not even have internet connection. So how can we talk about things like AI tools that are offline fast, for example? How can we spread these offline fast solutions to actually work for this low resource environment? Because even if we go back to the slide that had AI use cases, majority of those use cases are being supported by internet connections, say the least. Majority of these solutions need high-level devices. Think about ChatGPT, for example. If you take ChatGPT, the application itself, to a community health worker right now, that community health worker's device cannot handle ChatGPT. A lot of, unfortunately, and I hope I'm not lighting up any fires, but if you think about the way we actually need to democratize AI in Africa, it goes deeper than even. It's really the little simple things, you know. We need to have solutions that are able to operate in our spaces. Unfortunately, not a lot of people can have Samsungs or iPhones, and even when it comes to supporting systems, most of the support comes with low-end devices. Most of these initiatives will not be supported by high-end devices to carry these high-end solutions that we are thinking about. So it's more of a nudge rather than a question, and this can be picked up by anyone in the panel. So how is it that we are thinking about AI for low-resource environments? Thank you.
So two things. A lot of people have identified that problem and are making the back end. The back end will be AI and very complex, but the front end is USSD. USSD means your SMSs, which can work on a feature phone. So when you look at the prompts platform by Jacaranda, it works on a feature phone and means that it can be accessed by mothers all across Africa. The other thing that Kala is doing is, in terms of the mobile phones, there is in Rwanda we had a side session as part of the AI Summit talking about smartphones for Africa. And here we are thinking about how do we make smartphones in Africa which are adapted to a setting. And one of those things is what you've talked about, making them be capable to run these AI native applications. And even just the applications which come with the phone, TikTok, or will it be something that is health related? So all those are considerations, and I totally agree. It is a concern, and I think people are working towards that.
I think I'd also say that, you know what Fred said earlier, that let's be curious. Let's spread that curiosity to the people we work with. I also work with some low-income areas within Nairobi, and you'll be so surprised how a mother with a child who struggles with disability may not have food for the day, but she'll be able to get a little airtime, or even how they share networks. Like you'll find there's somebody within a plot that has Wi-Fi, and they buy Wi-Fi for 30 shillings, and everybody is able to access some form of Wi-Fi at some point. And so part of what we've also been doing is educating people and saying, if you're gonna spend 3 hours on TikTok, you can spend 20 minutes learning something from that phone, getting some information, even just on simply typing what is AI, and you'll be surprised what information people can learn. So as much as we are curious as health practitioners, when you have a patient, tell them when you go back home, go learn a little bit more about your condition. Go check out what else is there out there that relates to your condition. Let's teach the people around us to also be curious. You know, you'll be surprised how grandparents in the villages in Kenya are on TikTok. And they're using those apps. So the thing is just not only to use apps for entertainment, but let's make people curious to also use apps for education and for growth. Thank you.
Thank you, Debbie. Back to co-creating, co-developing, co-testing. It can be an app that can work for us. Dr. Shiko, did you have a comment?
Hi, everyone. I wanted to comment on that. I mean, you spoke very passionately about that. So in the next couple of weeks, hopefully, by mid-May, we are releasing a paper that is called Resource-Constrained AI. And it's looking at the 5 pillars of an AI ecosystem: talent, compute, data set, use cases and market, as well as governance, and looking at that from the lens of how do we make this possible for Africa. So we're very doing that. But also, the big thing about doing this is also quote-unquote dumbifying what AI is every time you talk about AI, people think imagery, flash images and stuff. Jacaranda, and I've just asked Keith to showcase the Atunzi website. You can actually interact with Atunzi on SMS. Because what we've done is we've built, and you can just access it on USSD and SMS by texting, and it texting you back, right? Very simple, because we're very aware of what is happening. Here in Nairobi, we have edge computing startups that are building and saying, how do you run models on your Samsung, not even Samsung S anything, just your A+ or A20, yeah, a very simple Samsung. So you're able to run models. So there are many, many experiments that are happening. Our team is trying to say, how do we support those researchers? We have researchers in our team who are building compute for the African continent, right? But other people are doing, how do we start building data sets that are able to train for our context? So this work is happening, it's not ignored. The thing is, we cannot wait for the perfect time for us to start. So we have to do all of these things in parallel, yeah? I always tell people, I'm actually going to San Francisco this week to beg for more compute credit. Why? Because we have to do research. We have to build. We'll borrow, beg compute credits, even as we're doing our own experiments on how do we build compute for the African continent. So it's a matter of starting with what we have, and that's why I'm pushing a challenge to you guys is, how do you, as medical practitioners, help us understand what are the gaps in the health space data sets, yeah? What do you need as a use case? How do we create a market for that use case? It comes from you and building backwards. So that's what I want to just point out. And when the paper is out, we will circulate to the people who signed up so that you can read it.
Thank you very much. Shiko, there was another question here. Farouk, I think there's another question here. And there was another question at the back. Also, we have 2 more.
Thank you. Farouk and team. My name is Dr. Diana Marion. I'm here as the Kenya Medical Association Secretary General, and I would really appreciate the invite, mainly because some of these conversations have to be very inclusive, and that is how we progress in really embracing changes that are coming along in the practices that we have. I'm a practicing gynecologist, an oncologist in training, and I'm a global health leader in training. So a lot of these things are very important to me. I would like to mention that I actually sit in the World Medical Association Medical Ethics Committee, and my conversation is going to go towards that direction. And I think one of the things we have to remember is that as healthcare practitioners, we have something we call the Declaration of the Helsinki. and it actually guides. And it has been revised many times, and I think I participated in the latest celebration that was held still in Helsinki about that declaration. That declaration tells us as healthcare workers to protect the patient's autonomy, confidentiality, do no harm, and many things, and a lot of those in health practice know that. So my first question would be this. When we are talking about AI in healthcare, how far back did we involve practicing physicians? How far back? Did we involve them in the development? Do we involve them in the design? Do we involve them in the validation for us to finally involve them in the implementation? And the reason why that is very important, so that at the end of it all, what we want is actually to meet the clinical needs of patients while still adhering to the ethical standards. So that will be my number one question. Then the other question is, AI systems must be transparent. And I think one of the presenters said, it depends on the information you feed it. And sometimes you need to, it's like nurturing it and growing it all the time and giving it specific data sets so that at some point it gives you the information you need. Now, if you're talking about that, then we need this to be reproducible. How is it? So if I am treating my patient here using whatever platform I want that has AI, is it the same with another doctor somewhere else doing the same thing? Based on the fact that we can have different inputs of the same thing. Then, when you're looking at clinical research, very keen on using patients as subjects. What are we looking at in terms of data privacy when it comes to AI? What are we looking at when it comes to informed consent when we're looking at AI? And what is the potential bias of AI algorithms when it comes to that? So I think at the end of it all, we must ensure that that really maintains all those things we have in the Declaration for Medical Ethics, and we must ensure that at the end of it all, as we embrace AI in healthcare, it must be responsive and sustainable. Thank you.
Thank you very much for those questions, Dr. Musa. The questions, thank you.
Thanks, Rachel. And thanks, Dr. for the questions. How far back were practicing practitioners involved in developing AI? It's a difficult and simple question in this sense. So, it's like the evolution of the internet. Yeah. No one really asked us what to put on UpToDate or Medscape. It happened. And it's a reference for a majority of people practicing right now. I mean, a lot of medical students, I remember doing ward rounds, and you'll ask a question and they'll all go to UpToDate and they'll respond to it. It's about embracing almost the inevitable, so to speak. And now that we're embracing it, before it gets too late and it has come and we have CT scans that already interpret the image as it were, based on data from the West, why can't we then participate early on in building solutions that are contextualized to our data sets? Because ultimately, yes, the models may be created elsewhere, but once you contextualize that model to what is here, then it becomes relevant to our practice. Ultimately, there has to be a human loop in adoption of AI, and it does not take away the responsibility, the clinical decision-making responsibility of the practitioner. It does not. And that's why it's a diagnostic support or a clinical decision support system. It cannot, and I don't think it will ever replace the human logic that goes into the Occam's razor mind that determines this is the diagnosis. I don't think it will ever get to that point. We'll still have a myriad of diagnoses that pop out when you say, I'm feeling unwell and I have a fever. Lyme disease may be one of those differentials, and it really does not exist here. Yeah? I think that is how I would respond to the first bit. So then it becomes the responsibility of the doctor who swore the oath to first do no harm, to apply the knowledge and apply it ethically. Yeah, and we should not let AI run amok, so to speak. The call to action is AI will come, it has come. How do we contextualize it to our practice so that it can make things better? Secondly, how do we have systems? I mean, I'm looking at Atunzi, looking at the system that Jacaranda have. I'm looking at the system that Penda Health is piloting on clinical decision support. How do practitioners in active practice then take up and do quality assurance for each of these systems? Absolutely necessary to have such systems because they democratize access. Whether we like it or not, there'll be 300 pathologists in Kenya for the foreseeable 3-4 years. Maybe we'll graduate 30 of them per year. I don't know whether we'll get to the 5,000 required in my lifetime. I don't know. Yeah. So if we could have a system that opens up access and probably pushes the routine cases further, it can interpret a blood slide and say this is possibly malaria. It reduces the speed, it reduces the time that is required for someone to go and stain. In my undergraduate in anatomy and masters, we used to go and stain slides in the lab. Just the other day, we've seen a doctor launch a lab that is entirely paperless, entirely slideless. There is no single microscope in that lab, but he's able to pick up diagnosis very fast. And actually, he's including diagnostic support from AI into pathology slides. He's able to process, about double the number. So what does that do to the patient who would have waited for 3 weeks to find out they have leukemia before they start treatment? So we embrace AI, but we counter-check it so that we don't let it run without an ethical angle to it, which can only be a human intervention. Yeah.
Thank you very much, Dr. Musa. Farouk, I think we had 2 more questions. At the very back. Thank you.
Hello, my name is Aradhana, and I work with diagnostics for a pharmaceutical company. My question is, what strategic role insurers will play in supporting AI-driven care models for predictive health and remote monitoring?
Dr. Musa, that's for you.
Thank you. I could see it was directly related. I can tell. Yeah, so this is the future. Let me just say this is the future. We don't want to be Kodak. Either we could adopt or not. The cliche in business school is Kodak did not adopt and they lost out on photography, and they were market leaders. Health insurance sustainability is dependent on 2 things. One is that we should be able to open up access to as many retail customers as possible. It's not a secret. We must make health insurance accessible and fairly priced and cheap so that a lot of people can purchase it, increase our risk pool, increase and improve our margins, and then probably make that sustainable. Second bit is, you cannot do health insurance from a curative perspective. It's not sustainable. It's the reason why a majority of health insurers, thank God we're not, don't make profit. And across the continent struggle with that. And when you don't make profit, your product will never be cheap. It is in the health insurer's interest then to invest heavily in preventive systems. Invest heavily in systems that can consume the huge amount of data that we get from the normal demographic data that you get from your customers to the the clinical data that comes in form of claims and be able to curate solutions that work for individual customers. And I'll give a live case example for Jubilee Health. If you went to your phone right now and downloaded the Maisha Fiti app, which is an app that Jubilee Health has built, part of what that app has, it counts your step, it monitors your water intake, how healthy you are, it exposes you to communities and so forth. At the end of the year, we'll actually pay you for being healthy. Yeah? We'll actually, sometimes, and I've seen 2 or 3 customers who had 2 million steps per month. My goodness, I haven't gotten there. 2 million steps a month. I think one of them, the discount was so substantive, we paid their premium for the year and actually gave them a cashback. Yeah? So there is room for us to partner in predictive analytics because we know that there are some inputs in that data that relate to good health outcomes. But that's not, I mean, this is a very small data set, this is a very small number of people. What could happen if we were able to expose this to everybody, you know, just have access to it and let's build the models better. What happens if, and I'll give an example of Japan again just to finalize my answer. In Japan, every year, it is mandatory from the state to do a health check, to do a wellness check. And they have this beautiful data set and they've been able to create a health profile for every single citizen. That's a dream come true for a health insurer. Because then at that point, you can be able to predict health outcomes almost accurately because you have a big data set, you can see how these patterns have evolved over time. I cannot wait for us to get to that point where actually we have that data here and we're able to curate products. You know, we don't set standard ratings, for example, for an insurance product, but it's just, I'm healthy, I don't drink, I don't smoke. Why am I paying the same amount someone who does the same thing? The only thing we share in common is we are the same age, you know, and we are male. Yeah, so over time, we'll be able to adopt, but there's absolute room for us to be able to use predictive AI in actually democratizing access to insurance. Yeah.
Amazing. So I think we had this last question, Farouk, and then we can close. Then we can close. Thank you.
Good evening. My name is Maureen Jerry. I'm coming in the capacity of MEDAC, Medical Technology Industry Association of Kenya. Thank you so much for the great insights so far. And my question is around regulations for AI-powered tools, specifically SAMED, the software as medical device. Given the rapid global uptake and the guidance available around IMDRF and WHO, how do we see Kenya positioning itself in terms of regulating SAMED? Thank you.
Dr. Fred?
Yeah, that's a good question. So I think it was in January, the PPB, that's the Pharmacy and Poisons Board, put out a call for a consultant to help them write the SAMEC guidelines, that's software as a medical device. However, I think it fell through because of USAID funding. So basically, people are doing a lot of thinking around regulation. So as you know, we did our strategic plan, which was launched last month, and Kala had a big role to play in that. So the commitment from the CS of ICT was to quickly follow up with an AI policy and an AI Act. Already, I've seen the draft of the Cloud Act, which has some sections on AI. So definitely things are going on, and also the Ministry of Health is actively exploring how to put regulation that is not restrictive, but also fosters innovation while protecting patients. So in summary, I think a lot of this is going on. And even as a continent, the AU is thinking about this, and that's one of the things that when you're in Rwanda, through color. That was one of the tasks in terms of the call to action and also having a harmonization of regulation across the African Union countries. So definitely work is going on that.
Thanks a lot for that feedback, Dr. Fred. I think I'd also just add that sometimes I say that, the fact that Africa does not necessarily have, regulations or laws on artificial intelligence is not necessarily bad. So it may also be a blessing in disguise, because then we're able to observe a bit more and develop regulations that are responsive to what we're seeing. Case in point, if you look at the GPDR, what we have in the EU, for example, the EU developed a regulation that is very restrictive. So they're experiencing an environment right now that is, a bit stifling, because they moved with the legislation first. So in African countries, what we've developed is really strategies. So 15 countries in Africa right now have strategies. We have 54 countries. So the others, about 30, don't have strategies, don't have policies, we don't quite have legislation in Africa, but I think we have the opportunity to observe. So we have the opportunity to even understand and say, okay, how do we manage this? And I think one of the ways that we're going is the direction of is the no harm direction, which is totally aligned with actually, the values, for example, in professions like medical care, professions like, legal, but also just as human beings, the no harm, protecting, fairness, etc. So I think I'll just leave it at that. We have the last question, and then I think we can close.
Good evening. My name is Deuri from Kenya Healthcare Federation, and we're the umbrella body for the non-state actors in health. And one of the things that I think we've grappled with, last year being 60 years after independence, still remains to be healthcare financing. And what practical applications can we have from AI on this, as a first question? The second question is on commodity security. If we do not sort that out, we'll end up with care that is affordable but unavailable. What are your thoughts, perhaps Fred and Musa, on this? And I think, Musa, you've been unfair to us, having something that is doing the claims journey very well. And since October I have not slept. Thank you.
Musa, you're in trouble.
So I guess I'll tackle the first bit. It's good to grapple since October. Lessons are learned in hardship. So hopefully the hardship time is done so we can learn. But just quickly, health financing has many facets to it. One of the solutions is to just address out-of-pocket expenditure, because then it pushes access. But out-of-pocket expenditure then has many downstream pockets where it goes to. We still have to address commodities. We still have to address our manufacturing capacity. We still have to address our human resource in health. So whereas healthcare financing is one of the building blocks of the health system, it doesn't necessarily address everything. But what can AI help in addressing and in sorting health financing? I'm not giving you a suggestion, Doc, but I know you're grappling with it on the other side. There's a very unpopular, and I don't like wading into those discussions, but means testing is very unpopular. The fact that when someone makes contribution to a fund, which they don't have a choice, but then the fund has a choice when it comes to paying for the care. So there's always debate there. One of them is, the way mobile loans are given. They will use your M-Pesa transaction and they'll be able to tell, this person has this ability to pay and so forth. It could be a very simple way of doing a means test and making these things fair across so that you can push contributions. But ideally, from the other aspect on operational efficiency, like I mentioned, the benefit is in reducing the premium cost. From a health outcomes perspective, the benefit is in the data and having a comparable outcome, having data that you can be able to compare across systems. But in terms of claims processing, I mean, the use cases are here. We have local data, it's done. So maybe in the other hat that you wear, Dr. you could come and maybe there are a few lessons we could exchange that could actually help in the rollout of the bigger system. Because ultimately the patient is at the center of this conversation, whether it's government or whether it's the private sector coming together to support.
Thank you so much. I think Keith, are we going back into the, no. We're not, all right. So thank you so much. I'll just hand over to Farouk. Asante.
As we draw to the end of the session, appreciate the questions that the audience have asked. If I could get Shiko on stage, please. And if I could get Monica from Jubilee Insurance to present to her a token of appreciation, please. If I could get Sean Jasani to present to Dr. Fred, please. If I could get Shez to present to Debbie, please. If I can get Lubna to give to Dr. Musa, please. And if I could get Nafisa to give to Rachel, please. So I'd like to thank our exceptional panelists for the enlightening discussion. Your diverse perspectives on the applications of AI in healthcare have truly broadened our understanding of the topic. A special thanks to Rachel for expertly moderating this conversation and guiding us through the insightful dialogue. I'd now request Nafisa from our Ismaili Civic team to give the word of thanks, please.
I just wanted to thank the Aga Khan Health Board and thank you to their chairperson Azmina, the MC Farouk, along with their board Shez, and their entire team. Thank you guys for organizing this AI Masterclass, which focused on the transformative impact of artificial intelligence in our health sector. I think all of us have learned something here today. This event delivered really valuable insights and really engaging and thought-provoking conversations. So thank you, guys. I want to particularly say thanks to our partners also who made this event possible today. Jubilee Health Insurance, thank you guys so much for always supporting us. Kala and your team, you guys were a wealth of knowledge. Honestly, thank you so much for all of the engagement. And of course, I think Farouk has already touched on it, but thank you to our panelists as well. Thank you to Debbie, to Dr. Musa, Dr. Fred, and of course Rachel for moderating such a wonderful and really thought-engaging discussion. Also, last but not least, I want to acknowledge our incredible catering committee. Thank you guys so much for always giving us hot, warm, delicious meals. Thank you to the Aga Khan Pavilion and Alina in particular for hosting us and for the lovely setup. And thank you to our safety and security teams who always make us feel at ease and comfortable. And last and never least, thank you to each and every participant who attended the session today. Thank you for taking your time to be with us. We hope you will walk away with valuable insights and on AI and healthcare. I know it's late, so without further ado, guys, thank you. Asante sana, everyone. It's been a pleasure sharing this space with you, and have a good evening and drive home safely.
Thank you, Nafisa. That brings us to the end of the day program for the day. We thank you for attending. We look forward to hosting you for future events. Thank you.